Hello, my name is Christine DiCarlo, and I'm the American Association of Colleges of Osteopathic Medicine's, or AACOM's, Media and Public Affairs Manager. I'm joined today by Dr. Sandra Snyder, who is the Program Director for the Cleveland Clinic's Center for Family Medicine Residency Program and the Chair-elect of AACOM's Assembly of Osteopathic Graduate Medical Educators Board of Directors. We will be speaking today about an innovative new family medicine education and training program, the Transformative Care Continuum, or TCC. The TCC program is a partnership between the Ohio University Heritage College of Osteopathic Medicine and the Cleveland Clinic to educate and train family medicine physicians with an emphasis on community health. Dr. Snyder, thank you so much for joining me today. My first question is if the osteopathic philosophy, which emphasizes whole person care through a primary care lens, help inspire the innovative TCC program?
Yes, I think it was really built on the osteopathic philosophy. This program, how we started was kind of in the end in mind and really going after a holistic osteopathic family physician. So even from the start with our recruitment process, we kind of changed the way we recruit medical students into this program. So most, programs rely on board scores and class rank. What we actually went for is more of the values and qualities of what makes a family physician. So, in our process, we actually created some unique behaviorally based questions. We went to our human resource colleagues and looked into things called situation judgment testing, which actually can test more around values. So things like empathy, adaptability, compassion, things that really make a quality family physician. And then, throughout the 6 years, we really focus on teaching our students and residents osteopathic manipulative techniques. In the hopes, especially in this current climate when we have an opiate epidemic, using tools like OMT is a nice adjunct to treating chronic pain that is very holistic. So our residents, when they graduate and practice, all are able to practice OMT and have that holistic approach.
That's great. That's really interesting. So it's definitely an osteopathic focus in mind. So my next question, TCC students are engaged in direct patient care, like you said, from their very first day of medical school. How much hands-on experience do these students receive during years 1, 2, and 3?
Yeah, so it's really unique that they're actually assigned from their first day of clinic, or first day of medical school into our clinic. And they are assigned to a team, and they have the same preceptors over their 3 years of medical school. So they really have that ability to advance their clinical knowledge in a short time because they have that continuity. How our program is set up is they're with us for 3 years. So you really get to know them, they get to know us, we get to really push them to a higher level clinically. The other component that we've added is not only focusing on their clinical skills, but focusing on skills that help them make our system a better healthcare system. So focusing on skills, we teach them, they all get a yellow belt in Lean Six Sigma. So they do quality improvement projects. And we have it with an eye of adding value to our practice. Their first year, they actually function as a medical assistant. So from their first day of kind of work in the clinic, they actually room patients, and in their second year, they function as a care coordinator and patient educator. And then as a third year, they take on a lot of the skills of third or fourth year medical students. So they're constantly adding value to our practice. Some of the things that they've done, and we've only initiated this program within the last 3 years, is they've improved some of our health maintenance recommendations like colon cancer screening. They've done projects to improve the colon screening for our patients over the age of 50. So it's really a kind of a novel curriculum where they have that clinical continuity, and then they have these added skills that they learn.
Yeah, that's great. It sounds like, they're obviously getting a lot more clinical education right from the bat than they would traditionally. But they're also, it sounds like, giving back a lot to your program, making recommendations, helping out with the patient. So benefits to both sides there. So my next question, TCC, it really is a truly innovative program, and it's part of the American Medical Association's Accelerating Change in Medical Education initiative. And do you see this type of program potentially transforming medical education in the future, and why or why not?
Yes, for sure. I think that this, being personally involved in this program, I think this is the way to train. We start just by the way that we've changed recruitment. I think we're, seeing that we're able to attract more underrepresented in medicine candidates because we've changed the metrics. We introduce them early on into the clinical environment. We teach them population health skills. We also are very community oriented and centered. I think one of the things that we've learned from the stress of the pandemic is that we really have to do better with our public health and primary care infrastructure and how we as primary care physicians relate to the community. And in this program, our residents actually do a community needs assessment, or our medical students do a community needs assessment, and they're required to do community projects. And because they have that continuity within our clinic for 6 years, they really make impact into our community. A lot of the medical school residency things are very fragmented. So you have, medical students spending, 4 years in a certain area, and then they do a residency in 3 or 4, and they really don't have time to put in roots. With this program, these medical students and residents actually put in roots and are given time to really focus on improving the health of their community. For example, we had a medical student who was very passionate about the homeless, and we have a part of our residency is we volunteer in a homeless clinic every Friday night. And she saw the need to help the homeless and really try to find, a sustainable solution for some of their problems. So she worked with an organization in our community called Frontline, which is an organization that provides sustainable housing and behavioral and mental health for patients with homelessness. And we now actually have a partnership with Frontline, and she's just beginning to do her residency with us. And we're going to continue having her for the next 3 years, and our other residents work there. We had another resident or medical student who is very passionate about the LGBTQ. This is a community that we serve within Lakewood. And he was finding that a lot of the homeless patients that he encountered were from our LGBTQ population. So he worked with the AIDS Foundation and got a grant to actually offer point of care testing for HIV for our homeless clinic. So these are just, 2 kind of examples, from a 3-year program. So for me, I feel just even though we're in the beginnings of this, we've just shown just how impactful this way of training can be, and just some of the outcomes that we can achieve if we continue down this path.
Wow, that's really impressive. Yeah, and inspiring that the students are making such a difference so early in their careers and early in this program. So talking about the pandemic, I know you mentioned that earlier, but it really truly has disrupted almost every aspect of our lives, and that includes medical education. And I know earlier on in the pandemic, the lack of personal protective equipment caused some major disruptions to clinical education. So I wanted to know if your students experienced similar challenges with this, or if there were any other challenges the pandemic caused.
Yeah, so this is a very interesting question, and very appropriate. Because we have that continuity with them, we were able to spend more time with them, making sure that we were able to make sure they were up to date with their clinical skills, making sure whatever they missed that they caught up. And in fact, reflecting back, we actually think that they learned skills that are so valuable. Just the fact of, how do you close a clinic? How do you create a process map and make sure that your most vulnerable patients are taken care of? So we always, because unfortunately, I think for a lot of students who have gone through the pandemic, there is a lot of anxiety because they have miss some components of their training. And we always reassure them that honestly, they have, lived during or trained during a pandemic, and they have amazing skills, and they should be very confident in their training.
Wow, that's again super inspiring that they were able to step in and figure out, how to keep that continuity of care for those populations. And yeah, it sounds like that's great training, and they were exposed to things they probably wouldn't have been before. Okay, so as you've said a few times, this is an accelerated program, and the TCC students graduate medical school in 3 years instead of the traditional 4. And you may have already answered this, but if there's anything else you could think of to add, I was just wondering how you ensure the students are learning all they need to know to be prepared for residency training within that accelerated timeline.
Yeah, so I think the beauty is, like I said, we are doing a competency-based education. So we have used the NBOME's competencies. And so every time we have a student, we actually fill out a competency eval on them. And we do several of them throughout their 3-year process. So and we constantly evaluate them. They evaluate themselves with self-reflection. We also have the ability to tape them. So we actually do peer observe video review with them from their first months of medical school throughout all 3 years. Having this kind of competency-based framework, having that continuity with the same preceptors really enables us to make sure that they're ready to practice. And I think it also enables us to add additional skills like the community-based work, the patient safety and quality work, the transitions of care work. The other unique factor that we're embarking on is we're creating this iPass, we call it, which we're using from Team Steps. It's kind of that when you do a sign out of a patient, you give something called an iPass. Well, we're doing an iPass between UME and GME. So we are getting when our UME students go to GME, we actually get an iPass competency-based handoff. So we can kind of see, where they stand. And a lot of the times we already know that because we've been with them for 3 years, but we get a competency-based piece. So we can say, okay, this person, needs a little bit more help in medical knowledge. This person, they really need more work with interpersonal skills. This person needs practice-based learning. So we can really tailor and create more individual educational plans.
Wow, yeah, I can't really imagine larger medical schools or programs will be able to do that type of tailoring traditionally. So that's a huge benefit. That's really interesting. So back to COVID-19, the pandemic really has exposed the serious work we need to do to address health inequities that stem from socioeconomic factors and social determinants of health. And I know you've touched on this a bit, but hoping you can elaborate again here how the program's graduates will help to make a difference in these areas.
Yeah, so I think a lot of it stems with a lot of their additional training that they get. So, that population health work that they receive, they learn the AMA's health system science component through their education. And they're learning how health systems work. They're learning how health systems are financed. They're actually learning how to write a memorandum of understanding with organizations. They're learning how to lead a meeting. They're learning skills like trauma-informed care, learning how to actually assess for social determinants of health, and then how to fill in those gaps. A lot of their work in their first and second year are actually with the interprofessional team. So their first year, their supervisor is actually a nurse. And then in their second and third year, they work very closely with a social worker, a care coordinator, a pharmacist. So it really helps them understand the different roles within the healthcare system and the healthcare team. Because as we move, some of the lessons learned post-pandemic is in primary care, we're going to need our team so much. Like the interprofessional team is essential because a lot of the issues that individuals face are not clinical issues. They're social determinants of health. So understanding that and having that ability to realize like, wow, this patient might need a social worker, or this patient, has some trauma in their life. They're going to need trauma informed care. And that's what we need to help them better take care of their health, are huge. So the curriculum really feeds into that. And I think that's really what's going to make them successful. We also, another piece that we've done a lot of work with is advocacy. We really are trying to pair like how they pair patient safety and quality. We really feel like pairing health equity and advocacy. So they learn a lot about health policy. They learn how to, write to their senators and legislators. We take them to the state house. We constantly are, looking to, AACOM and GME to work with governmental relations. So that's another piece that I think is often missing in medical education. And we so far, like I said, we've had they've gotten grants. Like it's amazing. Like if you can just see some of their early work in their 3 years of their community projects, you can see how they have that ability to look outside the clinic into the communities that they serve, which is often neglected because of how fragmented our educational continuum is.
Yeah, I keep thinking like how revolutionary all of this is as you're talking. I'm just like, this is great. You're like really addressing really important areas that seem like when you think of all the problems with healthcare, it can feel insurmountable. But this is like very inspiring because, you're getting people in the community, you're training them. I love the part about advocacy because these students, they're living this, they see the problem, they understand it really well. I think their voices will really go a long way to make change. So I love that that's part of it. I'm very excited. That's wonderful.
Yeah.
And so this July 1, 2021, the first cohort will begin their residency training officially. And what are your hopes for this first cohort of residents?
I just hope that they have an easy transition, that they just, embrace their clinical and community work. I also hope, my hope is that the TCC students and the non-TCC students become a cohesive team and really help each other and really work on trying to, post-COVID, really make the world a better place, really focusing on, and I think we have a lot of work to do, post-COVID, especially in the areas of health equity and, chronic disease. So I really hope that, they keep their passion and, desire to change. They keep that going.
Yeah, that's beautiful. I like that. All right. So my final question is, what advice would you give to other undergraduate and graduate medical education programs interested in pursuing a similar partnership? And from a GME perspective, what are the tangible benefits you've seen so far? It sounds like there are many.
So tangible from GME, yes, many, many, many. So some of the things that I can think concrete wise that you could see is the ability to really recruit underrepresented and minority, a better way to recruit underrepresented and minority because you're starting from medical school. I would say you have to match less residents. So you have, because the whole match process is very cumbersome. It's become, like in our program, we have to interview 100 people. It's very costly. Now that I've pre-matched half of my class, I actually can cut the interviews down and don't have to interview as many people. So there's a cost savings in that. And then there's just the time away from that piece. And, I think we all know that the match is very broken. That you often get people that aren't even interested in your specialty interviewing. It's just not as Like, I really like the process that we have where we have kind of our 3 programs and we kind of listen to their lived experiences, and it's a much easier component. The continuity of having students is phenomenal. It really, I think a lot of us as educators, you can see like you have a student for 1 month and by their 3rd and 4th week, you're like, oh, I got them where I need to be. Awesome. But then they're gone. I mean, to have somebody for 6 years as an educator in primary care is amazing because you can really push them, especially in a competency-based track, you can push them to a very high level and you can add additional skills to what they've already learned. So I think that's another component. The UME GME collaboration, it's oftentimes like we get students and we're like, gosh, I wish I could tell UME, like, teach them this because on GME, I got to reteach them this. Like the whole fact, like patient safety and quality is one concrete example. A lot of times UME, we're not teaching any component of patient safety and quality. And so then we would get them and we'd have to start from day one of what is patient safety and quality. And we have to teach that in addition to everything else. In our program, their first year of medical school, they get Lean Six Sigma. By the 3rd year of medical school, they're functioning like a PGY2 in patient safety and quality. So when I get them, I don't need to do much work with them. They're going to go very high. So that's, really, I think the tangible benefits.
Yeah, all extremely great, really inspiring. And I keep thinking about like how much this will benefit the community too, and all the patients there, and how it does seem like it has effects to really make positive change that will compound over time. So I'm really excited. I'm excited to see how they do next year, and hope we can reconnect then and get an update on the program. And really, I just want to thank you so much again for sharing this valuable information about this program. It really does sound like a great partnership, and I know it will have great benefits for community health. And I really hope other programs out there, UME and GME, look to it as a model for something they can try in their own areas. So thank you so much again, Dr. Snyder.
Yeah,
and
you're always welcome, and I think it might be in the future good, like in a year or two, you could always come back and actually talk to that, because I think that would be, I always think sometimes the most powerful speakers are the people that have gone through it. And I think just that's where we're really looking, once they've gone through the whole process, I think they're going to be the ambassadors to really get people to really want to kind of try these types of things.
That's a wonderful suggestion. Yeah, I love that idea. They sound amazing, so I would love to talk to them too.
They are. We always joke, we say that we would never get into the medical school residency if we applied because they're just amazing people, and they give me my hope post-COVID that the world will be a better place with them, in charge.
Awesome. Well, congratulations to you and to your students, soon to be residents, and to everyone listening today. Thank you for tuning in. Thank you again, Dr. Snyder. Take care.
Thank you.